Thank you very much for having me. I would like to thank Mort and the team for inviting me. It's a great honor being here. So I saw Paul was pressing for yes, because he thought after the talk then he could switch to no, so it would look better. And he's sitting over there, I saw that. He had his finger on the yes button. So before I dive into the topic, I just want to start off as a baseline here and emphasize the fact that there are certain things, as you all know, we can really not live without. And just to remind you what those things are, the slides actually don't meet, so the slides don't move. Okay, so let's dive into the data. So I think when we think about what's important, it's always good to go to data. So the evidence really comes from two meta-analyses. And these two papers, I will go over very briefly and show you how they clearly outline the importance of MRD. Before I dive into that, as we all know, with the older drugs for myeloma, only a small proportion of patients reached a complete response. So there's really no reason to talk about MRD. But this belongs to the past. Using the modern combination therapies, about 100% of our patients have a response, an overall response. And up to 80% of patients are reaching a complete response. So it's really a necessary and logical step to go forward to look at MRD. We know that in patients who are in complete response, some of them are MRD negative and some of them are MRD positive. And there are smaller studies looking into this, and they have showed that in those patients who have a CR and are MRD negative, they have a longer progression-free survival, and there have been some indications that also overall survival is better compared to those patients who are just CR and MRD positive. So this is why these two meta-analyses were conducted, and they were published in September of 2016 and in 2017 in January. And these two meta-analyses are very similar. There is a little bit of a difference, but importantly, they show the same thing. The high points from the meta-analysis, and this is from the study published in 2016, is that the overall effect for PFS has a hazard ratio of 0.35 in favor of MRD negativity. And for overall survival, the hazard ratio is 0.48. So using more simple language, this means that MRD negativity reduces the risk of progression by 65%. And it also reduces the risk of dying by 52%. We already have implications of these facts. One of the implications is that we now have new updated International Myeloma Working Group criteria that were published mid-last year. In the response criteria, beyond complete response, MRD is now an instituted endpoint for clinical trials. For patients who are in a CR and also have been tested with a test for MRD that can deliver 10 to minus 5 sensitivity, meaning you can rule out one cell in 100,000 or better, that patient could be declared MRD negative. As you know, everything that's published in the New England Journal of Medicine is always true, so I will therefore show you a couple of papers from the New England Journal. This paper was published earlier this year. It's the combination of Velcade, Revlimid, dexamethasone, randomized, with and without an upfront transplant, and followed by 1 year of lenalidomide maintenance in this study conducted in France. This study showed that the transplant arm was the winner, but they also stratified and looked at the response for the two arms. The primary endpoint, as I mentioned, is to look at progression-free survival, which was better in the transplant arm, and therefore that arm won. If you look at the reason why that happened, is because you have more patients in CR. Now, if you take the approach of MRD, which has been done and is coming out in an updated paper from the same group, you see that patients that are MRD negative with both these two arms have very similar progression-free survival rates. There are more of those patients in the transplant arm, and that's why that arm won. But if you really looked in the individual patients, you would see that they are very similar progression-free survival rates in the two treatment modalities. Sticking to the New England Journal of Medicine, the same pattern actually is already published in the relapse setting for myeloma. Using daratumumab with lenalidomide and dexamethasone in the randomized phase 3 trial, daratumumab Lendex versus Lendex in patients with 1 or more prior lines of therapy first showed that the 3 drugs are better than the 2 drugs, but then took one more step forward looking at MRD. If you stick to the 10 to minus 5 sensitivity criteria, which is in line with the International Myeloma Working Group criteria I just showed you, you see that in patients with multiple myeloma who have relapsed disease, up to almost 25% of patients are MRD negative, which is kind of amazing. This is the first paper in the field of multiple myeloma reporting on a randomized phase 3 trial for relapse disease that talks about MRD, and 25% of patients reaches that with the 3-drug combination. This is a very big step forward. Now, if you break down the results with the 3 and the 2-drug combinations, and you look at MRD status, this is not the primary endpoint of the study, but you see very similar patterns for progression-free survival. So I think this raises a very relevant question. Is MRD more important than the treatment modality? And we heard beautiful presentations earlier this morning by Garrett Morgan and Nikhil Munshi on the complexity of the biology of myeloma. We know that every patient does not have the same myeloma. So it makes sense that some patients have myelomas that are responding to a little bit less intense therapy, while other patients have a disease that is more aggressive and maybe takes a little bit tougher therapy to get there. But if you reach that point, that seems to be really what matters for progression-free and overall survival. There are additional implications, and this is moving very fast forward. The FDA is looking at other diseases for surrogate endpoints. CML has molecular response for the approval of the Gleevec drug. I think myeloma is going to go there very soon with MRD. Looking at the FDA administration rules for surrogate endpoints, they say that a surrogate endpoint actually can lead to an accelerated approval. And after an accelerated approval has been given, the study needs to continue and provide at least a progression-free survival. I think myeloma is going to get there within the coming 1 to 2 years. That's my personal take on that. There are still pieces that need to be worked out when it comes to regulatory aspects. The level of sensitivity has to be studied in both newly diagnosed and relapsed patients, the role of the biology, the timing of the testing, and also the statistical models needs to take into account individual survival and censoring time. So we're not yet there, but this will happen. This will happen in myeloma. Other implications that we're already seeing, and the field has just started, is the development of new assays. Years ago in the UK, Andy Rostrom and others started developing early flow assays for MRD testing in myeloma. And it was based on their work in chronic lymphocytic leukemia. The work continued. There were groups in other countries, in Spain and elsewhere, and also here in the United States, people worked on these assays. Improving flow cytometry, you can find 1 cell in 100,000. Go into molecular assays, you can take it at least 10 times more sensitive. And we don't really know what the end game will be in terms of sensitivity, which assays will be the best. That remains to be tested in the future. This is an example of a liquid biopsy that we have developed here at Memorial Sloan Kettering using a MALDI-TOF mass spec assay that is probably 1,000 times more sensitive than conventional protein assays. We find very, very low levels of protein in the peripheral blood. There are a lot of other applications with RNA and DNA and circulating cells. This is a field that's going very fast forward. This is another example of work we are doing in our laboratory. We have developed immunopet technology. We have labeled antibodies that show that there is residual disease here in mice. And we hope to go in doing these studies in humans in early 2018. I will end my talk by addressing implications that I think are going to happen in the near future when it comes to treatment management. And in my clinic, my patients are already asking me these questions. And of course, we don't know the answer because the data is not yet there. And I will use data from a paper that was published very recently in Clinical Cancer Research. And for the purpose of the debate here, the lead author, I was one of the co-authors, but the lead author is Paul Richardson's supervisor. So he took the lead here, Ken Anderson. So looking at MRD negativity after combination therapy, so this is the standard RVD or KRD or whatever you use. A hypothesis that needs to be tested in the future is really early MRD negativity, something that could prompt us to say there is no need for an upfront auto transplant in a more formal way. Another question is, for patients who have been treated with a transplant, if you turn MRD negative after the transplant, does that mean that you don't need any further consolidation if you're using that in your current practice? It's another question. Another hypothesis is for patients who have been treated for a long time on maintenance therapy, and they continue to be MRD negative over a long time, could you stop the maintenance and monitor the patient? And another hypothesis is for patients who are not transplant candidates that are treated on continued therapy, which of course is very similar to the maintenance situation. Could patients who remain MRD negative go off and be tested and maybe come back to therapy if there is evidence of recurrent disease? These are all hypotheses, and I don't know the answer to it, but I think these are questions that more and more people are going to start looking into very soon. So before I wrap up my talk, I will give you a little summary of what I think Paul will tell you. So the debate is MRD ready for prime time? And as I have showed you with all the data, the answer is yes, and most of you voted yes. But Paul will tell you it's too complicated. He's going to tell you why it doesn't work, and it's a research test, and all these things. And he's going to say, well, let's just press ignore for all the data. Don't worry about it. But as I already pointed out in the beginning of my talk, there are things you cannot live without, and you know that. So when it's time to vote, please remember, I'd like to thank my collaborators, and I thank you for your attention.